degradation. Okay? And the advantage of this drug is if you have a patient who is in severe liver failure or severe kidney failure or has liver and kidney dysfunction, all right, this would certainly be a nice agent of choice, because when you stop administering the drug, even though they have significant dysfunction of their liver and kidney, the drug will get metabolized, it will get broken down, and you will not have a patient who is unduly paralyzed when you wish them not to be, okay? So that's atracurium. All right, which leaves us with ketamine. I left that for last, again, because it's not something that we use all the time. It's a great drug, once again, if you know how to use it and know when not to use it, all right? Onset, probably 90 to 120 seconds. Its peak is in about 10 minutes. Duration, highly variable, usually about 30 to 60 minutes, very patient dependent. All right, let's talk about the side effects. All right, that's what makes ketamine interesting. Ketamine causes increased secretions. All right, you need to know that. If someone is using ketamine to intubate someone, it potentially could be a problem unless the intubation goes very smoothly. All right. You could talk about using atropine as an adjunct, all right, is what we usually do in order to decrease your problem with secretions that ketamine causes. The other thing it does is cause increased blood pressure, all right? Doesn't sound like a good agent if you're worried about an intracranial hemorrhage in the head or increased ICP with a head trauma. Right? You don't want to go around, and we're not talking a little increase in blood pressure. We're talking a significant increase in blood pressure. So it would not be a good choice for a head trauma patient. However, it might be an excellent choice for a patient in septic shock. Okay? All right. It has an increased incidence of seizures, all right, because it lowers your seizure threshold. If you have a patient who has a history of seizures, or you have a patient with a history of a head injury, or anything that would increase the relative risk of having a seizure, once again, ketamine is not the agent of choice for you. It also causes dilatation of bronchial smooth muscle. All right? Interesting side effect. If you have an asthmatic, could be a very nice drug of choice, all right, if you are having to either sedate them or intubate them, okay? And that's the thing about ketamine. It is also classified as an anesthetic agent, okay? Once again, it's mostly because the effect of secretions and the potential effect that that has on maintaining somebody's upper airway, all right? It's classified as an anesthetic agent. Ketamine, if you've never seen it used for something more like a conscious sedation, rather than, you know, in a semi-emergent intubation or for on a drip, the patients have a very unique reaction to it. They often have nystagmus. They often appear to maintain their consciousness, but yet they seem rather distant from what's actually happening. And that is a very notable effect of ketamine. Some people use this as a street drug, and I just don't understand it. To me, that would not be the kind of experience I would want to have, but you see that classically with ketamine. So there you go. So think about the medication profile, all right? What's your onset of action? What is your peak? How long is your drug going to last, okay? What are your side effects? Are there any side effects that you can use to your advantage, i.e. the bronchodilation in ketamine? Or is there a side effect that you really want to avoid, as in thiopental and a patient who's already hypotensive, okay? Look at, know your dose range in general. It's something, the more frequent ones you should know by heart. The other ones, make a cheat card. And again, the metabolism helps with some drugs, so that you know ideally which drugs to avoid if your patient is having dysfunction or failure of that particular organ, okay? Think about the difference between an agent, for conscious sedation versus anesthesia. Again, it's a continuum. Just any of these drugs that we're talking about, okay, not the paralytics, but any of the sedatives, any of the narcotics, the pain medications, you cannot tell in any particular patient what one dose is going to what endpoint you're going to get. You could be down on the conscious sedation side, or you could be way towards your anesthetic side with any of these meds. And that's why you need to be trained. You need to have proper monitoring of the patient with SAT monitors, with your heart rate probe, okay? And you need to be able to handle their airway, because certainly with any particular patient that's under duress, you can get an effect that is outside your expected range with a proper dose, okay? And think about which drug fits your profile. Think about that, all right? Do you want the patient to be comfortable for an hour, all right, and well sedated and paralyzed and for an hour? Or do you want something that's only going to last for a very short period of time? And that's where knowing your onset and your duration come into play, okay? You don't have to know the exact numbers. Just, know that fentanyl and Versed are usually our quick agents, all right? They're rapid onset, relatively short duration, okay? Morphine and Ativan are much longer, their duration is not that much prolonged, but they are certainly, their onset is not that much different than Versed and fentanyl, but their duration is certainly much longer. The same thing about the paralytics, okay? Rocuronium is characterized as a rapid onset, short duration drug. Your vecuronium and atracurium are in the middle. And your Pavulon is a longer acting agent, okay? So that's how we pick, and that's how you should be helping us, all right? And to pick your medication choice, all right? Think about your goal. Think about what you're doing. What characteristics do you want from your ideal drug, okay? And then pick the medication that fits that the most closely, or most importantly, avoids any problem that you do not want to encounter, okay? All right, and you've got to practice, okay? This is not something that you can just, listen to once, put in your hat, and forget about, okay? So I absolutely encourage you to make a cheat sheet, include this information. You can summarize it however you want, but you should have this at your fingertips when you're in a clinical, any clinical situation, whether it's in an MRT or on a transport, so that you can pick the best choice, all right? Because you will be seen as the person who is most trained to do this, okay? All right, thanks.